Respected seniors and dear friends, today I am going to talk about paravertebral block, a novel approach for pain management in thoracic trauma. Myself Dr. Hetal Vadera, I am from Rajkot. This is an attempt for a teaching on a forum the anesthetists. If we talk about thoracic trauma, among road traffic accident, 8% of the admissions are because of thoracic trauma. And among that, rib fractures are commonest of chest trauma. Thoracic trauma is a marker of severity of injury and it contributes significantly to morbidity and mortality. If you look in history, management of blunt chest trauma has evolved from World War II. From 1930 to 1950, it was done with external stabilization of chest with various devices like wires and plates and etc. Mechanical ventilation was introduced in 1956. Initially it showed good results, but in next 20 years it was realized that it was associated with many complications like ventilator associated pneumonia, and it increases morbidity and ICU stay. So in 1975 a study came with routine use of mechanical ventilation versus other techniques like good pain management, good physiotherapy, and steroids and fluid restriction to treat the chest trauma, and it showed good results. After that, it is a common practice to provide good pain management in thoracic trauma and to provide good chest physiotherapy and better patient care. Today, paradoxical movement of flail segment is not considered a major clinical problem. It increases work of breathing a bit, but such patients require assistance with oxygenation rather than ventilation. So if you provide good pain relief, good physiotherapy and oxygenation, you can treat the patient without putting them on ventilator. Ventilation is required in head injury patient significantly, pulmonary contusion, after major abdominal surgery, and worsening of respiratory failure in spite of adequate pain relief. If your PO2 is going down, your PCO2 is increasing, respiratory rate is increasing, and oxygenation is not maintained, then you go for ventilation. So why to give good pain relief in this patient? As we know, pain limits ability to cough and breathe deeply. So if we don't provide good pain relief, patient cannot breathe deeply and cannot cough. That will lead to sputum retention, atelectasis and reduction in functional residual capacity. All this will lead to decreased lung compliance, ventilation perfusion mismatch, hypoxemia and respiratory distress, and patient will go on ventilator definitely. So good pain relief is very important in thoracic trauma patients. Now we will discuss what is ideal technique for pain relief. It should be safe and simple. It should provide complete and long-term analgesia. Analgesia must be complete and for long-term and continuous. It should not be peaks and drops and peaks and drops. It should be continuous pain relief. It should permit deep breathing and clearance of secretions. So there won't be any atelectasis and pneumonia and problems like that. It should allow cooperation during chest PT. It should provide good pain relief to do chest physiotherapy. It should improve respiratory dynamics. It should have minimal central and systemic side effects, and it should permit early mobilization. So these are the requirements for good pain relief. So what are the various techniques? There are many techniques like systemic opioids, intercostal nerve blocks, interpleural analgesia, thoracic epidural, that is gold standard for thoracic trauma pain management, thoracic paravertebral block, that is a newer technique for pain management in thoracic trauma. TENS and oral analgesics are used for very minor injuries. So if we discuss these techniques, systemic opioids, it is a very simple technique. It does not require any positioning, and we can supplement to other technique also, but it is associated with CNS and respiratory depression. So patient will have respiratory depression with it, and there will be cough suppression and nausea. So it is not an ideal technique for providing pain relief in thoracic trauma patient. Another technique is intercostal nerve blocks. It is a highly effective technique for 8 to 24 hours. Basically, it was introduced first for pain management in trauma, thoracic trauma. It has got no CNS depression, but chances of risk of pneumothorax are very high with it. Another problem with is there is difficulty to find first to seventh rib because of scapula, and it is not suitable for posterior rib fractures. It requires multiple injections, so there will be discomfort to patient, and chances of pneumothorax are high because of multiple injections. Similar technique is intercostal LA with catheter. You can put a catheter in intercostal space, but it provides for analgesia for few segments only. So it is not ideal for multiple rib fractures. Next technique is epidural, and it is gold standard for thoracic pain management. It gives superior analgesia to any other technique. It has got no CNS depression. It has got opioid sparing effect, and it gives bilateral analgesia with high success rate. But problem with epidural is if you put epidural catheter early and if you give the dose of epidural, then what happens? Patient will go in hypotension because patient is hypovolemic, and sympathetic supply is blocked, so patient will go in hypotension, and sometimes patient may go in cardiac arrest also. There is a risk of dural puncture and spinal cord injury if it is done by inexperienced person. It causes motor blockage. So it is problematic particularly in lumbar spine injury patient. It causes urinary retention, and it may mask signs of intra-abdominal injury. If patient has associated abdominal injury, then it will mask the signs, main sign of intra-abdominal injury, that is pain, which will be masked. So these are the merits and demerits of epidural. Next is epidural opioids. It requires low dosage. It gives good bilateral analgesia with good hemodynamic stability. It has got intact motor function with good sensory pain relief, but it is associated with urinary retention and pruritus. There is also nausea and vomiting, and risk of delayed respiratory depression is there. And pain relief is not as good as epidural local anesthetic. So we can use combination of both local anesthetic and opioid, and it gives excellent analgesia with less side effects. So combination of opioid and LA is best among all. Next is intrapleural LA, that is placement of a catheter inside pleura to provide pain relief. It has got no CNS depression and no need for multiple repeated injection. But what happens if you put intrapleural catheter? You have to block the ICD for 20 to 30 minutes. That will create a chance for tension pneumothorax. Another problem is you have to make the patient supine so that local anesthetic trickle down to posterior side and block the posterior nerves. Otherwise, what happens if you keep the patient upright, then local anesthetics will go on diaphragm, and it may block diaphragm, which will worsen the respiratory failure. So it is not very good technique, but it can be used. There are chances of LA toxicity are there with this technique. Now, newest technique is paravertebral block. It is technically very simple, safer and easier to perform than thoracic epidural. Palpation of rib is not necessary, and scapula does not interfere in needle placement like in intercostal blocks. Uninterrupted chest tube drainage, so there is no chances of tension pneumothorax. There is no CNS depression. It maintains hemodynamic stability as compared to epidural. It preserves bladder sensation, and there is no lower limb motor blockage. So this is a better technique than epidural, particularly in patient with unilateral injury. But there are certain problems also. There is a risk of pneumothorax with it. Dermatological spread is not as predictable as epidural. So if you give local anesthetic, it may spread up to 4 pi segment, it may spread up to 6-7 segment, and sometimes it may remain into 2-3 segments only. It requires higher dose than epidural, so there are chances of local anesthetic toxicity. With epidural, you can give good analgesia with 6 to 8 ml, 0.2% ropivacaine per hour. But with thoracic paravertebral, you require higher dose, that is 8 to 10 ml per hour. So these are the various techniques. Oral drugs and TENS is used for very minor injury. It is not useful in severe injuries. So now we will move to thoracic paravertebral block. What is thoracic paravertebral block? It is basically a technique to block thoracic paravertebral nerve when it comes out of intervertebral foramen, and it will give ipsilateral somatic and sympathetic blockage. So it is like a unilateral epidural, and it gives better hemodynamic stability than epidural. So there is an advantage over epidural. If you look at anatomy, it is a wedge-shaped space. Here you can see this is wedge-shaped space, and it is formed laterally by pleura, posteriorly by superior costotransverse ligament, and medially by the vertebral body, intervertebral disc, and intervertebral foramen. It is continuous laterally with intercostal space. If you see in sagittal section, it is formed anteriorly by pleura, posterior by superior costotransverse ligament, and these are the transverse processes. In between that is the thoracic paravertebral space. So if you inject local anesthetic in thoracic paravertebral space, it will spread medially to epidural space, it will spread laterally to intercostal space, it will go in cranially towards upper paravertebral space, and it will go caudally to in lower paravertebral space as well. So with single injection, it may spread in many segments. There are mainly two techniques, LOR technique and ultrasound guided technique. In LOR technique, you have to mark spinous processes which you want to block. Then after marking the spinous processes, you have to mark a point 2.5 centimeter lateral to the spinous process. You can palpate C7 easily and count below T1, T2, T3, T4, etc. So this is the point for needle entry. You have to go perpendicular to the skin, then hit the transverse process. After hitting the transverse process, withdraw the needle up to skin and redirect the needle. When you hit the transverse process, mark the point where you hit the transverse process. So after withdrawing needle, when you redirect the needle, you should not go beyond 1 to 1.5 centimeter beyond where you hit the transverse process. If you go beyond that, you might puncture the pleura, and there is a risk of pneumothorax. To prevent pneumothorax, always attach a syringe to the needle. So if you accidentally puncture pleura, air will not enter in the pleural cavity. So this is the LOR technique. Here you can see this is the spinous process of upper vertebra, which lies parallel to the transverse process of lower vertebra. And this figure shows the technique of paravertebral blocks. Here you can see initially needle is hitting the transverse process, and after redirecting, it is entering in the thoracic paravertebral space, and drug is spreading in upper and lower spaces. You have to select the space according to the dermatomes. So you have to select the space where you want to give analgesia. This is the video which shows how thoracic paravertebral block is given with LOR technique. Here you can see I have marked the spinous process, I have marked the 2.5 centimeter. I am hitting the transverse process now. Now I am redirecting the needle caudally. I am hit the transverse process at 3 centimeter, and I am going now I feel the loss of resistance at 4 centimeter. Now I've started injecting the drug. This is transverse process, this is pleura, and this is superior costotransverse ligament, and drug is coming in the thoracic paravertebral space. So you can give with LOR technique thoracic paravertebral block very nicely. Now this is the ultrasound guided technique. This is paramedian sagittal approach. Here you can see this is the transverse process, this is transverse process, this is pleura, it is moving with respiration, that is lung sliding, this is posterior superior costotransverse ligament, and my needle is coming out of plane. So after reaching the pleura, I will start injecting the drug, and it will push the pleura anteriorly, and drug is coming here between superior costotransverse ligament and pleura. Now I will show the spread of the drug in upper and lower thoracic paravertebral space. Here you can see it is spreading in the upper space 1, 2, and some drug is in third space also. So it has spread in 3 segments. Now we go in lower space, here you can see there is drug, there is some drug, and in this segment also there is drug. So with single injection I have blocked at least 5 to 6 segments. And when you want to put the catheter, you have to inject some saline to expand the space, otherwise there will be too much of resistance. There are some certain complications associated with thoracic paravertebral block, like pneumothorax is very common, 0.5 to 1%, but clinically significant pneumothorax is comparatively very less. If you direct the needle medially, it will go in epidural or intrathecal space, and there are chances of total spinal, and there are reports of total spinal with thoracic paravertebral block. So be careful, never direct needle medially. Even with thoracic paravertebral, as you can see in this photograph, I have put the catheter in thoracic paravertebral space, and I have injected the dye, and dye is spreading medially toward the epidural space. So there is always some spread in epidural space with thoracic paravertebral block. Bleeding, infection, and local anesthetic toxicity are other complications. There are certain contraindications. Absolute contraindication are local infection or sepsis. Patient refusal is another contraindication. Local anesthetic alergy or toxicity, tumor in paravertebral space are other contraindication. Relative contraindication that are for anesthesia with thoracic paravertebral block are sternotomy, midline laparotomy, where you require bilateral thoracic paravertebral block. You can put, but it is better to put epidural rather than putting bilateral thoracic paravertebral catheter. Severe respiratory disease, thoracic spine deformity, and ipsilateral diaphragmatic paralysis are other contraindications. Some clinical pulse, always do marking with marker pain. Even with ultrasound technique, otherwise you will go more laterally, and sometimes you give intercostal block rather than giving paravertebral block. Use needle with depth marking so that you can exactly know where you hit the transverse process, and you should not go 1 to 1.5 centimeter beyond that point. Depth of transverse process varies at different thoracic level. It is minimum at mid thoracic level and highest at upper and lower level. Don't advance needle 1.5 centimeter beyond contact point with transverse process, otherwise there will be pneumothorax. Avoid directing needle medially, otherwise you will go in epidural space or subarachnoid space, and there will be either epidural or spinal. Inject saline to expand the space for catheter, otherwise there will be very high resistance as compared to epidural. Very easy passage of catheter suggests intrapleural catheter. So if your catheter is going very easily, then you are in pleura rather than in thoracic paravertebral space. Always attach syringe with needle while locating for space to prevent pneumothorax. Use multiple injection when you want to use for anesthesia. So take home message is, without adequate analgesia, deep breathing, coughing and chest physiotherapy are compromised and respiratory failure ensures. Intubation and mechanical ventilation is required in selected cases of thoracic trauma only. Even if it is required, good pain relief ensures early weaning in such patient. So always provide good analgesia in this patient for earlier recovery and earlier discharge. Thank you all for your attention. Thank you very much.